Welcome, everyone. I'm Dr. Diana Bitner of True Women's Health, and let's chat about summer-ready legs. I care about this so much because, as you know, I don't like to see women suffer. And I'm here tonight with Dr. Laura Kelsey. She's a general surgeon and regional medical director for West Michigan for the Center for Vein Restoration. Welcome, Laura.
Thank
you
you
so much for joining us tonight.
Well,
Everyone can care about, we hate our legs when they get achy at the end of a day. And of course, if they don't look great for those summer shorts. So I would love to hear why you care about this and maybe a little bit about your career journey that got you to this point.
Sure. Well, thank you first for having me and for spending your whole career working on women's health. I mean, I see it every day too, where we're just told that we should just deal with it, live with it. It's not that big of a deal. And then when we bring up a cosmetic issue, or even a pain issue, it tends to sway into an apology about it being cosmetic. And so I really applaud you for giving women this opportunity. My career was a little different in how it started. When I was in practice, in medical school and in residency and even into practice, there wasn't such a thing as a vein specialty. Between my second and third years of medical school, my mentor said, hey, why don't you go to Hawaii for your 8 weeks and do vein research? And I said, gosh, nobody in the world knows about vein research, but everybody's heard of Hawaii. So I'll pass on Grand Haven. I went to Hawaii. And I didn't really understand that that would be really the foundation for my entire career work, right? The following year, I presented in Bulgaria on protein CNS deficiency and factor V Leiden, which became now well known as the most common cause of blood clotting disorders that's inherited. It affects many, many people, but at the time, that was in 97, that was just case studies that we were presenting.
Oh, wow.
Yeah, the following year, I went to London to study hypercoagulable states. And my mentor was a hematologist, so that was her goal for me to become a hematologist. I went into surgery and then produced papers and research on how do you prevent clots in patients, knowing what I knew, how do you do risk assessments. And I focused on trauma patients as I was interested in trauma surgery at that time. Those patients are at high risk for clot and high risk for bleeding. When I finished residency, I did not do a vascular fellowship because vascular fellowships, only about 5% of their curriculum was actually focused on vein disease.
Oh, wow.
So that's changed. But in 2005, I left my general surgery practice to focus on veins only. And since that time, veins have really grown into its own subspecialty.
Well,
but
Laura,
that was my course.
Laura, a couple things. Like every time I talk to you, I learn so much, seriously. Like, again, everyone, I just love that I have these colleagues that know so much. And I mean, I just love hanging out with Laura. But then when we get nerding out about women's health or the science of this, like she is so smart and she so knows what she's doing. I have to admit, I kind of thought it was more not cosmetic, but I thought it was something, and then you and I get talking about the risk of blood clots. And, that's something that sometimes we're concerned about with women taking hormones. And so to be able to talk to you and really understand the science of this and give people facts, not just opinions, but really give people data. So again, I applaud you and I thank you so much for being a colleague. I've already sent you patients and I just so love working with you. So anyways, let's get into this tonight. I think this all starts with, how we feel every day and those heavy, achy legs. Like, women just think they have to live with this. Tell me more about that.
So the statistics show that by age 50, about 50% of women have some degree of vein disease. There's 40 million Americans in our country with vein disease, and about 1.9 get actually referred for treatment. What that means is veins don't have their own nerve supply, so when they break, or a valve breaks, so to speak, and we'll discuss that at some point, you don't really feel that. What you feel is a gradual change over time where you're like, I don't know, my legs are tired, but I'm tired. They're heavy, but I'm gained 10 pounds. They ache. And, you find yourself rubbing them, and then you go through the menopausal thing, and you're like, good Lord, what's what here? And so we see that women start with these symptoms when they're pregnant. They seem to get really bad with the second pregnancy, and then they stay there. So when you deliver the baby, obviously the veins regress, but that disease process has already started. And then we see them present 10, 15, 20 years later with rip-roaring varicose veins. And a lot of times when they approach their primary care docs, they say, well, do they bother you? And the women don't have this aha moment. So they're like, how do I answer that? They're not painful. And so the docs are doing their diligence, maybe trying to ask the questions, and we're trying to figure out what's what here and how I feel. So restless legs can be it, swelling can be a symptom, cramping can be a symptom, tired, heavy, fatigued legs. And so it's very subtle. It was clear to me, I sat down on the couch and I put my feet up, and that's like my space in the corner. And my husband always has his feet down. And I said, why don't you put your feet up?
Right.
And he said, because it doesn't help me to put my feet up. And I thought, aha, what woman doesn't come home and put their feet up? That's right. You turning gravity off, which is starting to calm down that vein pressure that's built up over time. So, it might be pretty subtle. And a way to test whether you have a vein problem or not is try some support socks. And support socks come in a lot of different varieties. They don't have to be the mannequin grandma pantyhose that are thick as wool. They can be a pair of compression leggings from Dick's Sporting Goods. Nike makes them. Under Armour makes them. Lululemon makes them. Old Navy has some. And so this has really become an opportunity for women to say, okay, if I put these compression hose on, what feels better? Those are vein-related symptoms that you're trying to control with compression.
Well, I think about, having delivered babies for 25 years, I saw a lot of women develop varicose veins. And just to go back to a little bit of the why, it's kind of like, when the baby's in the pelvis, it keeps the blood in the veins in the leg, and it's an obstruction, right? So there's more blood in the veins, and there's those valves in the veins. And so the valves swell, the veins swell, and the valves can't keep the blood going in the right direction, right? So they get stretched out. Mm-hmm. And then I think about what happens in perimenopause and menopause is that as we lose estrogen, we lose collagen. And when I talk about, collagen is like the building block of our skin, of our veins, of all of our tissues. And so that collagen breaks down, the skin gets thinner. So not only can you see them more, but of course then the veins, right, expand more and, as you say, break.
Yeah. Yeah, so the veins, if you think about arteries, which we've talked about arteries ad nausea for women, veins are 5 times more common than arterial disease, but most people haven't heard of it. And so veins are like roads. So if I said, hey, Diana, meet me at, Meyer, you might go your way, I go my way. We don't have to drive every road between here and there. We just have to arrive, right? And so that's how veins work. There's a vein in the deep system that's surrounded by muscle. So the muscle is what makes that differentiation between superficial and deep. And that muscle does 2 things. When you squeeze it in exercise, which is why exercise is so important, you're pumping the blood up. It's like a sump pump. And then gravity pulls. And that muscle structurally supports that deep vein. So those valves come together like they're supposed to. So it's abnormal to have dysfunction of the deep vein unless you've had damage to that deep vein via a clot or some pelvic congestion, which are, not as common as varicose veins. Superficial veins run parallel to that vein, but they don't have that same structural support. Those are called saphenous veins. So there's a long one that goes from the ankle to the groin, or we call it the long or the great. There's an anterior one, and there's a short one in the back. And the idea is as you breathe, the blood gets sucked up and gravity pulls. So every couple centimeters, there's a valve that prevents that blood from sliding backwards. And that's what my research was actually in Hawaii, is pulling that vein out and finding those valves and putting some numbers to this. So what happens is because those veins don't have that structural support for the reason you mentioned, they're prone to break. So it's a genetic problem that you inherit. And then you have babies, which puts a mass, right? So the veins got to go from the groin up to past the belly to the heart. So that functional obstruction. The increased blood volume creates more pressure and work for those veins. And then estrogen's a vasodilator. So women will, like before their period, they might have really sore legs. That's how people know that they're pregnant. Their legs start to hurt sometimes. And even going through menopause, they'll see some of those leg achy symptoms too. It's the estrogen effect.
Right. And so, what are risk factors? So you've talked about pregnancy. So women with multiple pregnancies, or let's say a pregnancy with twins, I would imagine would make it even more with more babies there, right? Sometimes just being overweight and carrying weight in your midsection, can that do it?
Yeah, so there are a lot of studies showing obesity is related to it, but when they looked at obesity, it's not a BMI of 25 or 30. It's when you carry over 100 pounds of weight, what happens is your fat in your belly just functionally compresses those veins, similar to the gravid uterus.
Sure.
And so when the veins are trying to, the valves are very important up to the groin, but then the rest of it is just kind of sucking the blood up through that space. And the veins are very compressible. There's no muscular wall to them. So if you have a heavy belly, it just, when you lay down, you just crush that vein. And so it creates a functional obstruction. So for patients that lost over 100 pounds, they can relieve that central obstruction functionally. But in the process of having that weight, those valves downstream of that pressure have broken. So you might still have varicose veins as a result of that, but at least you'll relieve that central pressure, so you won't have recurrence after recurrence after recurrence.
So if someone's thinking about having their veins, even losing a little bit of weight before surgery probably makes it less likely to come back.
It does.
Yeah? Mm-hmm. Okay, good. What about other risk factors? Smoking?
Smoking is not associated with vein disease. It's associated with clots strongly. So one of the first things that we ask people to do is, smoking is something that you can change immediately, and that's clearly associated with an increased risk of blood clots. So having varicose veins, one of the long-term consequences of it is that you can get clots in those veins. Smoking clearly increases your risk of that happening. And so the idea is, as the pressure builds in the vein gets bigger, the blood isn't moving as well, so it's kind of sluggish, and then you combine that with smoking, or you combine it with travel, and so people will present with phlebitis. They'll have a red hard spot. That is a clot. It's just a clot in that superficial vein. And clots in the superficial vein, 90% of the time stay put, 10% of the time don't. So if you have a red hot spot on your leg, you still need to look into that. You still need an ultrasound to determine where is that? Is that going into the deep vein or not? So smoking is a risk factor for that.
Cool. Well, we've already had a question, which I love. Thank you, Karen. We're going to talk about spider veins, and actually that's kind of next on my list to talk about the spider veins versus the varicose veins. So let's start with the spider veins, because I want to talk about these two different kinds and basically, why do you get them, who gets them, and then what we could do about it, and what happens when you go see Dr. Kelsey and talk about this. So can you talk about, Laura, what are spider veins? I know I've got a couple. I don't love them, so I think I need to come see
Everybody's got one. So if you think about spider veins and you go to a pool, you will not find a leg without a spider vein. Once you start looking for these things, you'll see them. Spider veins are the very, very, very small, tiny. They can be as fine as your hair. The blue ones that don't really bulge, but they look kind of blue, like they kind of create a network on your leg, those are called reticular veins. That's a size step up. And then the varicose veins are the big bulgy ones that are usually fueled by an underlying problem.
Okay.
So spider veins can be part of that whole disease process, or they can be just spider veins. And so when you see us, you want to understand what's the extent of the problem. So if you have a cluster of spider veins that look like those spider veins in your medial ankle, on the inside of your ankle that you see every time you wear sandals and cross your legs, those are at the end of that saphenous vein. And so sometimes that is a presentation of a varicose vein. It just presents as a spider vein.
Sure.
So the categorization of these different veins is size. Okay, so saying it's a spider vein or a varicose or whatever is based on the size of the vein. But the reason for that can be variable. It could just be that you got kicked with a soccer ball 10 years ago, or I keep running into the same counter, and so I keep getting a spider vein there. Or it could be fueled by something bigger. So the study that helps us clarify that is an ultrasound. So the first time I see patients, even if they say, no, it's just a spider vein, I don't have any symptoms, I say, okay, I understand. But I have to tell you first that if I'm going to recommend a treatment, I need you to understand if this is the right treatment based on where this is coming from. And I need you to know that if you choose to just treat the spider vein, that might be the choice, and we might both agree to that, but we might still have to do surveillance on this. So the story would go like, I never had these spider veins until I had this. I had a patient that had, I think, liposuction and said, I never had these until I had that. I said, well, let me do an ultrasound. And sure enough, their saphenous vein was broken. So she just, all of a sudden, that pressure built up, and it was spider vein, spider vein, spider vein, spider vein, and it was all in a column. And that's how her saphenous vein was breaking and presenting to the surface. So ultrasound really helps you clarify where you're at with this disease stage and what is the appropriate treatment.
Sure. So who gets spider veins? Like you said, just everybody?
Everybody. So family history, veins are genetic 80% of the time. So if you have
just like what Courtney's saying, it's genetic for her.
It is, yeah. And so people will say, well, I never looked at my dad's legs. Genetics come through the dad too. So you'd want to look at grandma, dad's mom. But 80% of the time there's some sort of history. And what do you do about that? You can't pick your parents, right? So that's there. And again, it's very common. It's about 50% of women by age 50. So it's more common to have one version of that than high blood pressure, actually. So it's very common.
I was having a little power issues here. Let me make sure I'm plugged in. Good. So in terms of Courtney, you were saying, what can I do to prevent more varicose veins from forming? So you've already had procedure done, I'm taking it, Courtney. So what can be done to make them, she's already had them treated. What can be done to make them from coming back?
Blood clots and varicose veins are typically from the fact that you have a varicose vein. And so if the segment is very long or it's close to going into one of the deep veins, we will treat people with blood thinners. So you will see us do superficial clots will be treated with blood thinners if those conditions are met. So it requires an ultrasound. And then, of course, we would turn around and try to get rid of the varicose veins and say, okay, if I get rid of the problem, then you're not going to, the impetus for that problem, then we're going to help that problem go away. Now, if you are having clots and superficial veins that are not varicose, we worry about cancers, actually. So some cancers present as clots. And so when you see me and your doctor thinks you have phlebitis, I'm kind of digging through this, trying to figure out, is that a varicose vein? Does that make sense with your history? Or, shoot, where's your health screenings? Are your health screenings up to date? Things like that. So in answer to her question, if they saw the vein, they assume it's from a clot, and you had varicose veins and they get rid of that, essentially your risk goes away when you get rid of the varicose veins. So varicose veins have a 4 to 5-fold higher risk of a deep vein clot with varicose veins. And there was a study done that looked retrospectively at hip surgery patients and knee surgery patients. And it divided people into 3 categories: people that had hip surgery that had a varicose vein, people that had varicose veins that were treated, and people that never had varicose veins. And they found that people that had varicose veins treated assumed the same risk as people that never had varicose veins, indicating to me that that's a cure.
There's something
right?
bigger up. Oh, right.
Yeah, so that getting rid of the veins is helpful in preventing clot.
Okay, cool. I'm looking at questions over here. Marla says, I had bad varicose veins from when I carried my twins without wearing support hose. Thank you, Missy. I went in because they looked horrible in the lower leg, but they go from the top to repair. I did one of the leg procedures before COVID and it hurt for almost a year. Not sure I went through the first procedure. Marla, I'm not sure what your question is. What do you think the question is?
So I think people can have, it sounds like you had an ablation, and that's where we start, is that saphenous vein is usually the problem. So what we'll do is numb up the skin and put a fiber inside the vein, and then we'll numb up around it. And then we'll use intense heat, like 120 degrees Celsius, which is 248, 249 in Fahrenheit, very hot. In order for you to not feel that treatment, you have to have a halo of fluid around the vein. And when the provider doesn't put that halo of fluid around properly, it will hurt like there's a hot poker in your leg. And that typically is related to that tumescent, which is what it's called. I've probably done 18,000 of those. I haven't had that problem, but I think it's probably that the vein was feeding those varicosities below, so that vein probably responded to the treatment. But unless you treat those tributaries or those branches down below your knee, you're still going to have those. So what I would recommend is come in for an ultrasound. Let's see what's there and talk about what your experience was, and let's see if there's another way to do it, a way to fix that for you.
And Karen asks, if one gets a spider vein post-injury, say from a fall down the stairs, does that mean a bigger vein injury happened?
Not necessarily. So that's what my whole family has varicose veins. I wear support socks every day. But I get them from bumping into the table, and they're in the same location on my leg. And it's just because I whack it, I get a bruise, and then that bruise breaks that vein system. So that is possible. It's more when you see a chain of veins or they're associated with bigger veins underneath the surface. So we do that ultrasound to verify that. So there's clarity when you decide to treat something about what you really need and what your problems really are.
And Laura, that's what she just answered. Hey, Laura, spider veins versus varicose veins. Again, it takes that ultrasound to see. And so Dr. Kelsey would do an ultrasound and then she could see, what's what. And so is there a reason, again, it breaks down to the anatomy, but who gets what? I mean, basically, I guess to distill it down, if you have a spider vein or varicose veins that are bugging you, don't blow it off and go see Dr. Kelsey and her team and get an ultrasound. I think that is what it's coming down to.
Right. When we see people in our clinic, we set them up at the same time to do the ultrasound because You might call it a spider vein, but we didn't give you any proper medical training to be able to differentiate. So I set aside a proper amount of time to do the same evaluation if your veins are terrible or they're not.
Right.
And then what we do is we sit down after that. So that takes about 45 minutes. And if you have a lot of veins, it can take longer than that. Then we have you sit with the nurse and we go through your anatomy, physiology, we do training, and then you talk to me. So you're there a couple hours. And then we try to figure out how does that partner with how you feel and what are the reasons to do which procedure. And there's lots of things that go into making the decision. And then we can partner it with your insurance because, a lot of insurances will support you in treating this if you have symptoms. And again, your symptoms don't have to be, oh my gosh, I can hardly walk, my legs hurt so bad. It can be my legs are tired and they're heavy and I'm having a hard time sleeping and it's hard for me to finish, doing the dishes after cooking all day. It could be that simple. And insurance recognizes that you should be able to live your life, do your activities of daily living without pain, and they will support you in that.
And again, we talk so much, and I promise we'll get to the restless leg question. But we talk so much about wanting to reduce barriers and to really make sure people are supported so they can live their life and be free of this stuff. So again, they can be as healthy as they want to be. Can you talk a little bit about treatment? And then I promise we'll get to restless legs.
So the treatment that we do in the office is based on the anatomy, right? So there's a couple things. The saphenous vein can be treated with heat, which we kind of touched on. Basically, you feel a numbing shot. We put a catheter in. You don't feel that. We numb up around it. It feels like some pressure. It takes me about 10 minutes to do that procedure. Afterwards, you'll say, it feels a little tight in my thigh. Maybe you'll take a Tylenol, ibuprofen. You're free to do everything. That's the gold standard. Then compared to that, some people don't want those pokes and that numbing medicine and have had that experience like was mentioned earlier where maybe they felt the heat. So there is a glue called VenaSeal where you put basically an IV in there and you use a glue that we've used to close aneurysms for years. It's very safe. But essentially we super glue that vein closed as you pull the catheter back. The advantage is that you have less shots. The disadvantage is that it's a glue and people have reactions to that about 5% of the time. Okay. That the studies show that that's not inferior to ablation. It didn't say it's superior, but it was compared to, and they say, yeah, those are pretty equivalent. The third way to do it is with VenaSeal, and that's kind of think of it as like a spray and insulation. So it's mixed with a solution that we've used for years called polydocanol, and it mixes it with a proprietary foam, and it expands like insulation spray and insulation, and we trap it in the space. The early studies said it had about an 82% effective rate compared to ablation, which was 96%. But as people have gained more experience and become more comfortable with this technique, we're at about 92%. And so I use that technology for short veins where you can't use the heat, or if the vein's really twisted, it will kind of go around those branches. So that's the saphenous vein problem. Sure. Then you have to deal with the superficial veins. So if you have a big clump of veins, it's smart to just make a little nick in your skin. They're called microphlebectomies. It's not a stripping where you have big incisions. And I do the top part first, so that takes the pressure off, so that vein gets small, so I can make a real small incision, hide it in your skin lines, and just remove that thing. And through those two incisions, you're like, wow, I feel great. And you feel good pretty quick. Maybe you'll take some ibuprofen or Tylenol, but that's the pressure. That's the money shot. And then we use sclerotherapy either with the ultrasound to get at veins underneath or superficial veins to clean up all the branches. Those are the slowest to heal because you kill the vein and the blood is trapped there and it sits there until your body gets to it. Sure. So it's important to take the pressure off so those are small and be prepared to wait that out. So that could be 3 to 6 months for that to improve.
Sure. Well, everyone, I'm sure you can tell, I don't expect you all to remember everything that Dr. Kelsey just said. She's spent years and lots of experience. I was on her website this weekend before we chatted, and her website is really good. And there's this little bot that keeps popping up to say, can I answer your questions? And it's really a great website. So I really recommend that you check out her website and learn way more about all of this stuff. And hey, Renee, and hey, Vicki. But I definitely want to get to the restless leg question before we get into our tips and questions. Laura, can you talk about restless leg and how that applies to this conversation?
Yeah, I think restless leg is kind of like neuropathy. It's kind of this black box that, a lot of us get diagnosed with, but we're not really sure why. The studies on varicose veins and restless legs indicate that if you have significant vein disease, saphenous vein problems seen on ultrasound under the surface, and you eliminate that, about 50% of people will have a cure from restless legs. That means that there's some people that have other causes of restless legs that we're unaware of. And certainly if you came in and had a negative ultrasound, we wouldn't attribute your veins to be the cause of that. More to come with that. Also, women that have had chemotherapy, they say everything's because they had chemotherapy. Not true. One of my best friends is a breast cancer specialist. They refer patients who have been told for years that they're going to have neuropathy because they had chemotherapy for breast cancer. They also get varicose veins. And diabetics, everything's not because you're diabetic. You can have vein disease and vein disease. And so just be very cautious that you're not pigeonholed into a diagnosis when it's very possible that you could have more than one problem and could see significant improvement.
I love that. And the other thing, just to talk briefly about, is I definitely have patients who have varicose veins on their bottom, on their vulva, on their lady town, as we say. But tell me about that. Of course, in pregnancy, they show up more, but, I have patients who have achy pelvis. Sometimes it's pelvic floor muscles that are tight. But if you would talk just a minute about the veins that we can see on our bottoms and what that's about.
So you can have a problem in the pelvis with your veins as well. You can get varicose veins of the ovarian vein. So you'd think that the ovarian vein would drain to a vein nearby, but it doesn't. It goes all the way up to the kidney vein, and it joins the renal vein or the kidney vein there. So it has valves, and those valves can break during pregnancy. And so women will present with vulvar varicosities, symptoms like they're having their period, even though they're not having their period. They'll have pain after intercourse, bloating, back pain. It can be debilitating. Yeah. Partnered with that is a condition called Maythorna, and I did see a question about that, where your aorta comes down, which is your major artery. It branches to give a branch to the right and left leg. If that's sitting just right where the branch is, it can compress the iliac vein, which is up in the pelvis, and create a pressure. So it's like the lane is 8 lanes, and it goes to 1 lane and then goes back up. And so we know now that we can put stents in there, lift that artery off, and now all that pressure in the pelvis goes away. So if you're having symptoms like that, then, we would certainly want to understand what your anatomy looks like, and we can get a lot of information first by doing the leg ultrasound to see if we can detect that pressure. And then we can go on to do a pelvic ultrasound to see if that's correctable for you. And yes, that has gained, there's about 15% of women who have chronic pelvic pain that actually suffer from what's called pelvic congestion syndrome from those 2 etiologies, and there is a treatment for that.
Yeah, which is awesome. And I know there are some radiologists who are more comfortable with those studies than others, and I'm sure you know who those are. But again, everyone, I'm sure, just like me, you're very impressed in terms of, I feel very comfortable that Dr. Kelsey could take care of me. She's just got such a wealth of knowledge. And what I'd like to move into on these Let's Chats, we always go into 5 tips that I want to leave you with. And we've covered some of this stuff. So just to make sure we've been thorough. Number 1, this is a very common problem, but suffering is not necessary. Laura, if people come to you, so let's say 55% of women have this, what percent of women get relief from even some of these procedures that you've talked about tonight?
So our satisfaction rate is like 96 to 98%, and we track that regularly. We take surveys on everybody at 1 month, and we compare. There's some scores that we have. You fill out a bunch of paperwork that are tracking symptoms related to vein disease before and after, and so we're at like 96 to 98%.
Nice. That's lovely. Thank you. Good. And you're right across the parking lot from my office, so I'm so glad you're so close. Number 2, most women have several risk factors. So if women are thinking, could this be me? What kind of risk factors would they think about?
Does it run in my family? How many kids did I have? What do my legs look like? Again, the best thing you could do is slap on a pair of compression and see how does that affect you. And that is a prerequisite for insurance. So if you come in and say, hey, I did that and I tried that for 3 months and what a difference, then we're in a position actually to get you through insurance. So that is a prerequisite for a lot of insurance, that we prove or validate that this is a vein thing and that you've had an opportunity to try non-operative management first. And then we can get you cleared to go through the process of treatment.
Nice. So and I just love that. I mean, you're a general surgeon. You've practiced as a practicing general surgeon, doing surgery all over people's bodies forever. And so, again, the fact, I always love that adage in surgery, you should only do the surgery if you can fix the complication. So I would feel very comfortable with you. No to go up higher to the vein if there was an issue. So thank you.
That's right.
Number 3, lifestyle can help. So we talk about the seeds at True all the time, the 7 essential elements of daily success. And for those of you who don't know the seeds, you can go to our website, truewomenshealth.com, and look at our seeds ebook. But Laura, what lifestyle factors do you tell your friends and family even, or you tell me to do to help this not be a problem?
Well, don't ignore it. It doesn't have to be any worse than it is to get some information and empower yourself to make a decision. I think our previous generations let it get way out of hand.
Yep.
And then your treatment's more extensive. So as a younger generation and feel empowered to get the data, understand what you can do to slow things down. Doesn't mandate treatment, but let's do that. Let's get the information right. Make sure you're going to a reputable place. You do not want to go to a place that says, yep, you need everything ablated, because that might not be right. So just because someone offers you treatment, look at it critically, because we want to do treatment that makes you feel better. But if you need a foot surgery, I'm not going to do a vein surgery if you need a foot surgery, because it has nothing to do with your veins, so you need intellectual honesty with that. And then, like I said, try the compression, stay healthy, do the things that Diana's been talking about all along is, do what you can do on your side. I tell patients, drink more water, elevate your legs, wear your compression, get walking. You can do more for yourself than I can do. If you lose 30 pounds, 50 pounds, I can do my part, and I'm happy to do that. But your overall health is going to benefit you more than any one treatment that I can offer you.
And 2 weeks ago, we talked with Mitch Shooks at Grip Training Gym, and I've started training with him, but it's like building muscle. I know is just going to help me not have to do as much vein work, hopefully. And again, I'll come see you, and then I'll be all set. Talk a little, if you would, about DVT. So deep venous thrombosis. This is something we screen all of our patients for in terms of their history of DVT. So if someone comes in and of course you find out they've had a DVT, how does that change what you might offer them or what you do for them?
So DVTs in general, there's an estimated 300,000 deaths in our country per year. So compare that to COVID. When we hit half a million, the world was shut down, and we have 300,000 every year estimated because we don't do postmortems. In 1970, there were 630,000 deaths in our country from pulmonary embolus. The thing about blood clots is you don't know you have a blood clot. Only 5 to 10% of people that have a clot below their knee even have symptoms, and so they're very, very dangerous. I lecture to doctors. I help doctors set up ways to assess this in their office. I speak nationally on how to do this. But what you need to know as a patient is you can assess your own risk. And so if you went to venusdisease.com, Dr. Joseph Caprini is the most versed in this. He has a model, and basically you can download this app and you can apply it to yourself. And what you do is you answer the questions, and it calculates the points, and the points translate to risk, and it shows you what the American College of Chest Physicians guidelines are for prophylaxis in regards to that risk. So if you think you're at risk for a clot, or you think your family members, shoot, my sister just had a blood clot, then use this model. So if you're going in for a gallbladder surgery, then you can run the model. This is the same model that's employed in hospital systems across the country. Now, if you've had a blood clot to me, I'm not going to not treat you because of a blood clot, but I will run you through that model, and I'll say, because you've had a blood clot, I'm going to have to put you on a prophylactic dose, a low dose blood thinner, to help reduce your risk of clot because you're at high risk. Doesn't mean you can't have it. It just means we have to make appropriate treatment options, and we have to use prophylaxis where appropriate to reduce your risk. Those medications will reduce your risk by up to 95%.
Very cool. And I think it's really important in terms of what you just said, that the medicines will reduce your risk. Even taking a baby aspirin can. But, if you're going to go on a long car trip, or you're going to go travel, or if you sit all the time, if you're going to go in for surgery, heaven forbid you're diagnosed with breast cancer and have to sit and have chemotherapy, all those things add up. And heaven forbid you have one thing and now you have a complication with another thing. So it's really important to be informed and to make sure you're taking care of yourself. So please save this website to the side. So if you hear in the family someone's talking about it, like, run that risk factor for them or for yourself. And tip number 5, the veins can be treated safely and quick. So let's say that someone is diagnosed, they come in for a procedure. Just real briefly, how long does the treatment take? And then what's the recovery like? You said just Tylenol afterwards, but.
So, depending on if you need pre-authorization through your insurance, that would slow us down in terms of a start date. We try to get people in within a couple weeks of calling us for a consult, get that information, and then we'll tell you at the time, listen, you qualify via your insurance, but it will take 4 weeks. We can do 2 appointments a week safely, so people tend to do that and power through. Average person would have 3 to 4 treatments per leg. So when they start, they're like, I don't want to see you 8 times. And by the time they're done, they're like, I can't believe this is our last visit. So, it's like, I have some people just come in for coffee. So you become part of our family when we're going through it. So I don't think it's as cumbersome. You can do normal activity afterwards. We just want you in compression for 3 days.
And how long do those treatments take when you go in for a treatment?
So an ablation takes me about 10 minutes, 10, 15 minutes. A phlebectomy about the same, but the process could take about 45 minutes. The sclerotherapy appointments are 15 to 30 minutes.
Okay, perfect. Thank you. And so now we get into those questions that we want everyone to be able to ask their healthcare provider. Again, this is just, I want you to be informed when you go see your primary care doc or whoever you see for your healthcare, to be able to be informed. So question number 1, my legs are achy and swelling. How do I know if this is a vein problem? So Dr. Kelsey has touched on this a bit, but I don't know, Laura, what you want to say about this, but again, she lectures to doctors about this when I was, of course, taking care of people before surgeries or, again, Laura, what would you tell a physician or tell a patient?
So if you have a swollen leg, it will respond to compression, but not every person that has a vein problem has a big, obvious varicose vein, right? That's a misnomer. About 40% of people present like that. Some people just have a swollen leg. And so you don't want to get a wrong diagnosis. So getting an ultrasound and finding out that your veins are fine and have me say, okay, well, I think it's this, that, and the other thing. We can still explore other reasons for the swelling, and we can clearly say it's not your vein. Or we might say, holy smokes, you've had 5 blood clots. There's a whole bunch of blood clot in your leg that you never knew about. Different problem. So I don't think a swollen leg is something to blow off, especially if it's unilateral, one leg. It's typically vein related. So let us look. Let's answer the question. And those are reasonable things to explore. If you go to the hospital for an ultrasound, they're going to check you for a blood clot. They're not going to check you for function. So if you say, well, I had an ultrasound, well, that doesn't mean they checked you for
function. What kind of ultrasound?
What kind of ultrasound? And the codes are the same for both ways to do the ultrasound. So it's the way it's ordered. So if you come to our clinic, we're going to do the deep clot study, but we're also going to do a functional study to say, how are those valves moving the blood flow in your leg? So It's a much more involved study.
Again, I just love it when we can know about our bodies, and then we have the information to make decisions. So
right.
That's just awesome. Question number 2, do I have varicose veins? And so again, as a person goes into their doctor and asks that question, again, it sounds like we already have the answer. You'll probably know that before because you're going to wear some compression stockings. And very briefly, Laura, somebody asked about where do you buy thigh highs without a prescription? And someone said pharmacies that sell durable medical equipment.
Yeah, so you're gonna. So you can go on Amazon. Has 17 pages of compression.
What do you recommend for starting? How strong?
So I found that if you're starting, I can get women to wear compression leggings. They stay put. They're a lighter compression, but they feel good and they're usable. So I'd rather have you spend $30 on that than $80 on a thigh high where you're like, it comes out and it looks like it belongs to your toddler. And you're like, that's going in the drawer or in the garbage. And so nobody can put that on. So if I'm starting out new, I would go, Amazon has leggings. We have stockings in our office. So if you come in and you've tried that and you're like, I need a good pair of stockings, then I will fit you. I will show you what our options are. We get them at a discounted rate because we do them in bulk. We can have them shipped to your house. That's a much better option for you. But if you're just starting, I'd start with a $15, $20 pair of socks. Start with something lightweight and just see. You can always bump up the compression. Obviously, the taller, the tighter the sock, the better, but nobody wears them. So
nice, especially in the summer heat.
Right.
Perfect. That's practical advice. Thank you. Question number 3. Again, I always want you all to ask your doc or your primary or your healthcare provider, what is my phase of ovarian function? So if you're headed into late perimenopause, that means that you're going to start to maybe see more of this vein issue. And so, ask, how is this going to affect my veins? What can I expect? Because again, I want you to know what to expect and not be surprised by stuff. So always know where you are in your phases. Question number 4, I think I have varicose veins. What testing do I need? So again, I want you all to ask your healthcare provider, but you've heard tonight from Dr. Kelsey, it sounds like you need an exam by an experienced person and you need an ultrasound.
Yeah,
So
and there are a lot of people that do vein work, like I said, so you really should not go to the hospital for vein disease. I mean, we have 7 clinics in West Michigan, Midland, Saginaw, Lansing, Portage. We have 2 in Grand Rapids and Wyoming and over by Diana's office, and then 1 in Muskegon. And so those are the clinics that, I'm the director of. And so we have 3 doctors, 3 PAs, probably 14, 15 vascular techs that are all specialty trained to give me the data or give our providers the data that we were talking about today.
Sure.
So you can pick a clinic, you can call our site, which is, I'm sure they'll list it for you, but you can call a common site, find out where you live, and you can see any of our providers, and we'll get you in the next couple of weeks and get you that data.
No, I love it. I sent you a patient. We were a little concerned about risk of hormones and her history of varicose veins, and you were able to help, and we got an answer and made a plan. So I was very appreciative of that.
Absolutely.
And number 5, question is, what can be done for my achy vein? So again, I'm hoping your healthcare provider out there can answer, but I think now you've got a really good resource in her website. And again, I can't say enough about the website. It was really easy to navigate through this. Again, this little bot kept coming up to see if I had any questions, and it really made a lot of sense. And again, getting to know Dr. Kelsey again, I hadn't seen her for a while, and we reconnected, and to hear all that she's doing and all that's available at the sites, again, I was just beyond impressed. A real quick question from Kristen: if time allows, can you discuss post-op UV exposure? She didn't realize her legs had to be covered up. Is that true?
So with sclerotherapy, when you kill those superficial, all the big stuff is deep, right? So we're going to get rid of that, and you're not going to see it. But when you kill those superficial veins with sclerotherapy, the process is you put the chemical in the vein dies, the blood is trapped there. So the look is not better. If they're really, really fine, there's not a lot to be trapped in there because it's a very fine vein. So those tend to disappear faster. But yeah, if you put that dead vein in the sun, it will pigment. So it'll draw more radiation than the rest of your tissue. And you'll end up with a brown, black, mucky. We can always tell when people have been in the sun because it's not a normal color that you would turn. So we don't have control over how long that takes to heal. Some people it's fast. Some people it's 6 months. It can heal for a year.
Wow.
It's the same process. I go out in the sun and I get freckles. So how do I avoid that? I don't let my skin get tan. It's not, sunscreen's not going to protect it. If I'm still getting brown, those veins are going to get darker. So in our clinics, you'll see us say, yeah, that's one we're going to do in the fall. And we try to pick these windows of opportunity. So you can still do your varicose vein stuff now. You can still feel better early. You can even do those in the summer. But the superficial veins, you have to stay out of the sun. So we will instruct you. We'll say, hey, what's your sun like? What's your sun exposure like? I'll have that conversation before I inject anybody, because if you're going to Hawaii, it's not going to look better for that trip. Let's just do it when you get back. So we will tell you that. Yeah. And that can be irreversible. So that's a bummer. So we will strongly encourage you to defer that treatment into a better time.
Awesome. That's such a practical tip. And just last question, Courtney says, how long does it take for the holes to go away? I think that sounds like that would be a surgical issue, how big the incision was. And I think Courtney's referring to incisions that were where her vein was removed.
Yeah. So we all close our holes. So we have incisions where there's a straight line, and we try to angle it so they're all kind of goofy in your skin. But that's because those are the way your skin lines heal, so that it kind of blends in and it doesn't look so obvious. Some people don't close those because they're so tiny, and then it depends on how big that is. You can start with a small hole, but if you're pulling a big thing through it, that hole stretches.
And if it's at a pressure point, like on your wrist, it's going to stay longer, get bigger.
Yeah, exactly. So we try to avoid the knees. We try to avoid the ankles. If I do that, you'll see me put an outside stitch in. If your skin is so thinned out because that vein has just moved all the fatty tissue there and there's nothing to hold together, then I'll put an external stitch in there and I'll let it sit there for a couple weeks. Because you can have skin damage from that vein in a slow healing process.
Sure. It's just amazing to me how time goes with these. It's just so fun to talk all about this, and there's so much to know. So everyone, again, I so invite you to check out the website for Dr. Kelsey's center, the Center for Vein Restoration. I'm just, again, looking forward to years of working together, sharing our patients and taking good care of the patients that trust us with their care. So Laura, thank you again so much. I look forward to hanging out, and everyone stay safe. Have a good night. Thanks for your time.
Thank you so much. Thank you.